What up? Put that on silent. What's going on? Good morning. I was gonna stop by the gas station, but it look like all they pumps out of service. So I'm Gucci. I play with it. What up, YouTube? What's the deal? Good morning. Just getting off work. Just getting off work. Just getting off work. How y'all doing this morning? Hopefully y'all are having a decent morning. Hopefully y'all are having a decent morning. This live is going to be dedicated to the new nurses in the game. Somebody in nursing school or somebody who's relatively new. Because I feel like the more seasoned nurses, especially in LPN, like LPNs, they know. Now this is pertaining to if you work in a nursing home setting, skilled nursing facility, assisted living, things of that sort. We're going to talk about how to deal with doctors in long-term care. Because I understand that some of y'all be getting intimidated by these doctors. Or, for the new nurses, dealing with a doctor, talking to a doctor can come off as very intimidating. Because, I guess you kind of look at them as some sort of authoritative figure and all that. And you should always have respect, but yo, I think I'm back. I don't know what happened, but I think I'm back. Good morning. Good morning, good morning. Hopefully y'all can come back. Thank you for your videos. What's up, Laura? What's up, what's up? What's up, Queen Butterfly? What's up, what's up? Come on back in this thing. Come on back in this thing. Come on back in this thing. I'm gonna give y'all a couple minutes before I start spitting. I'll give y'all a couple minutes before I start spitting. What's going on? What's going on? Can y'all hear me? We back. We back. We back. Can y'all? Am I good? Am I good? Let me know if I'm good in the comments. Come on in. Come on in. Am I still paused? They say I'm live, so I might have to restart it over. Give it a couple more seconds. I'm good. Alright. I'm good. I'm about to end it. What's up, Lord? Congratulations. You about to kill it. You can kill that interview. You got this. You got this. You got this. But I don't know why YouTube paused the video like that. That's crazy. I don't know why they did that. Would you recommend becoming an RN if I'm 25 with a child? Brandon, yeah. Why not? What does being 25 and having a child got to do with being an RN? Of course. 100%. Of course. Why not? Yeah. These niggas acting crazy this morning. Is he drunk? Anyway. So, alright. I want y'all. So, this is for the new nurses, right? For the new nurses or nursing students. I was talking about how to deal with a doctor, how to deal with doctors in the long-term care nursing home. I've been a nurse for a little bit, for about 3 years, and you've been out of school since '03, going for my dream. That's what's up. Yeah, go for your dream, Lord. You got this. Heck yeah. You got this. And if you dealing with a dude who dusty, who trying to hate on you, let him go. Don't let nothing stop you. If you dealing with anybody in your life that's dusty trying to stop you, I don't care who they are, let them go. Because I'm telling you, this LPN school, like, it's not easy. It's definitely not easy. I'm for real, y'all. It's not easy. Like, people think because LPNs are not registered nurses that it's easy. It's not. I know a lot of registered nurses that say LPN school is a lot harder than registered nurse being like RN school. So like, it's not easy, bro. But I do want to talk to y'all about dealing with doctors, because I know a lot of some people get intimidated. I ain't gonna say y'all, but I know a lot of people do get intimidated. And I've never been that type, man, because doctors are people too. They're humans. They make mistakes. But I'm gonna give you some game on how to deal with them when you are calling them for certain things. And, when you're handling patients, whether you are in a nursing home setting, or you are in an assisted living setting, or, good. That's good. You got a good man. Everybody don't have that. You have a good man. Top check. Okay, let's see if that works. But, so, you are going to have doctors in some of these long-term care facilities that are garbage. Like, literally garbage. And they are only there for a check. Their only objective is to make the facility money, okay? Y'all have to understand that going in. That is something that I had to figure out myself. Every doctor is not the same. You are going to have some very good doctors. Like, I've been fortunate to deal with some extremely good doctors. One of the doctors that I used to deal with actually passed away not too long ago. This man was a phenomenal doctor. He was a guy that, he was just a great doctor, man. He was a doctor that you didn't have to be worried about talking to. No doctor like stupid stuff that you should know. You know what I'm saying? But like, and I ain't gonna even call it stupid, but he just, like, he wasn't like that. You know what I'm saying? And this was like the first doctor that I ever really worked with. Cool as hell, man. Like, I was a little hurt when he died, man, because he was just so cool. He would give me advice. You know what I'm saying? Shout out to, is that Patience? Shout out to Patience. Good morning, Patience. What's going on with you? Good morning. Hope you're having a good day so far. I'm just getting off work. So, just talking to the family real quick. But doctor was cool as hell, bro. We're going to call him Dr. R. But Dr. R, he was just that guy, man. He showed me a lot. You know what I'm saying? And unfortunately, he passed away. And then, I've dealt with doctors who were absolutely terrible. Like, terrible. And so, first off, the first thing you got to do going in, you got to understand what type of doctor you are dealing with, right? As working in these long-term care facilities, you have to know it's a business, right? So this is where critical thinking and nursing judgment comes into play when you are dealing with certain people. We are dealing with certain patients. This is when people say all LPNs do is push pills and all that kind of stuff. That's cap, because it's a lot of stuff that go into this. It's a lot of critical thinking that goes on, especially if you have a doctor that ain't worth a damn. You know what I'm saying? If you have a doctor that ain't worth nothing, you're going to have to do a lot of critical thinking on your own, and you're going to have to use your nursing judgment. But here's the first thing that I want to say, though. I want to say this off top. Never be afraid to send somebody to the hospital. I want y'all to get that through your head right now. Never be afraid to send somebody out to the hospital. If you feel that a patient is on the brink of death, or you feel like it's a situation to where this patient needs to be sent out immediately, then do it. Because you got to understand, this is your license on the line. Point blank period. It's your license on the line. You have to use critical thinking. Because let me tell you something. A doctor may tell you not to send a patient out, but guess what? What's the worst that can happen for sending a patient to the hospital? What, they fire you? I've never seen a nurse get fired, and I've sent patients out against the doctor's wishes, and I've saved lives for doing that. I've done it twice. I had one patient that was given classic signs. Look at these idiots up here. I had one patient that was giving out classic signs of going septic, okay? Classic signs of going septic. The patient had not been seen by the primary care physician for days, ladies and gentlemen. For days. So I'm up in there, and I'm looking at all the symptoms, you know what I'm saying? Elevated blood pressure, temp going crazy. That had a temp for God knows how long. Just showing the classic signs of going septic. And the blood pressure was just like super high. Man was having a temperature, but he was hot. He was saying he was having chills, but he was spiking the temp. You know what I'm saying? And just sweating, all kind of shit going on. You know what I'm saying? So, make a long story short, I called the doctor. Mind you, the doctor, this was on a travel assignment too. Mind you, the doctor had been to see the patient about 2 weeks, right? I don't know what he was doing. And I said, well, you know, these are the symptoms, yada, yada, yada. I really think he needs to go out. Patient very lethargic, blah, spleen. No, don't do that. Just give him Tylenol. What? Tylenol? Yeah, he been popping Tylenol around the clock. I said, Doc, I don't think this is it. He been getting Tylenol. The fever has not broke. This man is lethargic. He is dehydrated. He's not taking any fluids or whatever. Do y'all want to start? Do you want the RNs, or you want to call one of the RN access people to come start a IV for fluids, something? Nah, just monitor. Some doctors that's bad love saying that shit. Just monitor. That's what I'm doing. I'm monitoring right now, and my nursing judgment is telling me that this ain't it, bro. I said, Doc, I think I want to send them out. No, don't send them out. Don't send them out, because see, they don't like sending patients out. Some don't. Let me not say all, because there's some great doctors that'll be like, send them out for almost anything. So let me not say that. But I'm like, Doc, I'm going to send this man out. He ain't looking too good. You dig what I'm saying? Because he had an elevated blood pressure, but his heart rate was dropping. It was the wildest stuff that I had ever seen. No, it wasn't the wildest stuff, but it was crazy. So he was like, no, don't send him out. I said, I'm sending him out. Don't send him out. I'm telling you not to send him out. I am the physician. Blah, 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 blah. I said, Doc, I'm sending him out, and I hung up the phone. Called 911, let his family know the symptoms of what was going on, because technically, if the patient's guardian wants you to send them out, you have to send them out. If the patient wants to go out, and if he's not his own guardian, if the patient wants to go out and they're their own guardian, you got to send them out. But if the patient has a guardian, you notify the guardian of the symptoms, you have to send, and they say send them out, then you send them out. So I let the patient's family member know this is what's going on. Let them know the symptoms. And they said, oh yeah, send them out, please, please, please. So we sent them out, called EMTs. Everybody like, oh, Dr. Such and Such gonna be so mad at you. He gonna be so mad at you, or whatever. He's the medical director here, and blah, blah, blah. I said, I don't care. This man is not a DNR. This man is a full code. And we not about to be pumping on somebody's chest unnecessarily. So I said, I don't care. What are you gonna do? What are you gonna do? Beat my ass? The worst they could do is recommend getting rid of me. And then I'm a sue. So, I mean, what? For using nursing judgment to try to say somebody lied? Ain't that what we in the business for? So anyway, I sent a patient out. I didn't hear nothing from the doctor. The patient, the nurse called to get, I called the nurse to get a report. And then it was probably about an hour before I was about to go. The nurse called back to give us an update on the patient. He said, yeah, he was going septic. I said, I know. And they didn't want to send him out. They said, well, good thing he did. Good thing you did, because he was about to die. I said, I know. But that's how it be sometimes. That's definitely how it be being like, it's crazy. It's crazy how it be. But sometimes you gotta use your clinical judgment. And then guess what? The doctor apologized. He apologized because he knew he was wrong. He knew he was wrong. Because I sent that patient out. He knew good and well that patient should have been sent out. And that's what I'm saying. You cannot be scared to send somebody out. I've never heard of one nurse in long-term care getting fired for sending somebody out. And guess what? If they do fire you, so what? It's a million jobs out there. So when you put on your resume, why was the nurse fired? Or if they ask you about it, because I had a patient who displayed symptoms of this, and that. I really felt like he was or he or she was in bad shape. I felt like it was necessary to send the patient out to the hospital. I was just using my clinical judgment and my nursing judgment, and I did what I felt was best for the patient. It went against the doctor's orders, but I'd rather do that. Listen, any facility with common sense gotta respect that. Gotta respect that. But that's just if you're dealing with a psycho doctor, okay? With a doctor who should not really be practicing. And that's what you got to understand with these nursing home doctors too. You got to understand that they have so many patients. They have so many patients to take care of. It's damn near impossible for all these patients to get quality care. It's damn near impossible for all these patients to get quality care. You got doctors that's literally dealing with dozens and dozens and dozens of patients in long-term care. So it's impossible for those patients to get the kind of care that they deserve. But you being the nurse that you are, the thorough nurse that you are, you do what you can, and you make sure you take care of those patients to the best of your abilities. Because it's your license on the line at the end of the day. While they are in your care for those 8, 12, or 16 hours, or however many hours you are there. It's your license on the line. So if you feel like that you need to send a patient to the hospital, do not feel intimidated. Do not feel scared. Call the doctor, follow protocol, document. Make sure you document everything. Make sure you put that sent patient to the hospital because of whatever. Because if something happens and they need to go to court, they can pull those records and they can pull that documentation at any time, bro. They can pull it at any time. Make sure you CYA, cover your butt, okay? That's what I'm trying to tell y'all. Get y'all to understand. Some doctors do not want you to send certain patients out. But here's the thing. Now I'm about to give you the game on what you should do. When you call a doctor, right? When you call a doctor, this is how you should be. Because a lot of y'all call, well, I ain't going to say y'all, but a lot of nurses call doctors sounding crazy. Sounding like absolute lunatics. And I understand why some of these doctors be kind of irritated with a lot of nurses, because they call them unprepared. You don't ever want to do that. And I'm going to break this down in a shorter video to get straight to the point. You don't ever want to call a doctor sounding crazy and not knowing what you're talking about, okay? So like, for example, today, well, last night, I had a patient. I walked in a patient's room, and I could clearly hear that a patient had audible wheezing sounds. It sounded like like a car was trying to start. So my critical thinking skills came into play. I'm seeing that the patient is using his accessory muscles to breathe. Old patient is not a DNR. Patient is a full code. I got a patient, he's in his 90s. He's sounding crazy when he breathes. I'm hearing it as soon as I walk in. You don't need no stethoscope to know nothing. Congestion, all that kind of stuff going on. You hear it. It's right outside. So, okay, I see that. First thing I'm going to do is I'm going to check the vitals. You check the vitals. You hear his lung sounds. It's sounding crazy right now. You check the vitals and you check that SpO2. Make sure that SpO2, you want to keep that joint above 90. You dig what I'm saying? You want to keep that joint above 90%. You dig what I'm saying? Now, some patients, when they suffer from COPD or any chronic lung diseases, it may be their norm to be in the 80s, okay? But you don't really want it in the 80s. You don't want to be comfortable in the 80s. But you have some patients that naturally stat from like 87, 88, if they got a history of like COPD or something like that. So with that being said, once you get the vitals, you write down the vitals. Okay, you'll have people that call the doctor that don't even take vitals, bro. They'll call the doctor with no vitals. They'll just say, oh, well, this patient, something wrong. That's why doctors be getting pissed off. And if I was a doctor, I would get pissed off at that too. Because the most basic thing, the first thing they teach you how to do in nursing school is how to take vitals. So go take the vitals. So the first thing I did was take the vitals. Now, usually in nursing homes, and this is why I like skilled nursing facilities instead of assisted living, because nursing homes or skilled nursing facilities will usually have standing orders. A standing order is just like a basic order that you have when something goes wrong. Like if you look up a patient, like if a patient is having a fever or if a patient is in pain or something like that, and you need, Tylenol or something like that, it'll be a standing order like, okay, you can give it. You ain't got to call the doctor for something like that. Or they'll have like basic bowel protocol on what to do if a patient hasn't gone to the bathroom or hasn't had a bowel movement in 3 days. You got basic bowel protocol or whatever. You don't have to call the doctor for that. It's usually a standing order. Or if a patient has a fever or something like that. You have Tylenol, usually be like 2 Tylenols, 325 every 6 hours or whatever. That's standard, usually how I go. But it just depends on the person, because you got to make sure the person ain't allergic to Tylenol. You got some patients that's allergic or whatever. But anyway, so my guy, he was statting at 81. I knew immediately something was wrong. So the next thing I did, so on standard, they have a protocol. It's a standard order, 2 liters of O2. You know what I'm saying? So I instantly go to the oxygen room. I get the concentrator, put them on 2 liters of O2. My priority now, because this is where you use your nursing judgment, and this is where you think back in school, right? Your clinical judgment, you got to use prioritization now. You dig what I'm saying? ABC, airway. I'm trying to get this man not to pass out on me and die. Because if he was statting in the 80s all night at 90 years old, it's a good chance this man could have died. You dig what I'm saying? So after I did the vitals, okay? After I did the vitals, and I got this man up to a rate that I was comfortable with, I looked at his history. Because a lot of y'all agency nurses, y'all gonna be thrown in situations like this. So you need to instantly look at the patient's history, whatever charting system you use or whatever the case may be. This is why it's important to get a thorough report from the nurse that you was walking with, or whoever, or the nurse you was taking over for. Because some nurses will be like, this patient take this whole crushed and put in applesauce, blah, 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 blah. And you don't know nothing about the patient. You don't know nothing about the patient. That's it. You just know how they take their meds. Well, what are they here for? Especially if you're on a rehab unit. What are they here for? You know, what happened? How did they get here? What's their history? Can you give me something? You dig what I'm saying? Especially if you're a person that's never been to a facility before or anything like that. Hold on one second, y'all. Hold on one second. My fault, y'all. That was my lady. I had to see what she was up to real quick. But anyway, where is I at? So you want to look at the history. You want to look at the history of the patient. You need to see what's going on with the patient, or if they have a history of what's going on. I looked at it, looked at the medical diagnosis. I said, okay, I see this patient has a history of COPD, heart failure, and I also got a report that this patient has pneumonia. But here's what killed me though, and now I'm talking on some personal stuff. What happened? So the patient has pneumonia. The nurse tells me the patient has pneumonia, right? I don't see no note nowhere about pneumonia at all. And I look and I see the respiratory therapist had left a note that, well, patient is having no wheezing sounds upon auscultation, or whatever the case is, no breathing sounds, PRN orders discontinued, no antibiotics. But this is what I'm hearing. This is what I'm getting from the nurse, but I have no official documentation that the patient is on, it has pneumonia. This is what they saying. But I guess he was assessed, right? Because the respiratory therapist left a note. The respiratory therapist left a note saying that no audible wheezing sounds upon assessment and all that kind of stuff, discontinuing orders. But my thing is, if you got a patient with pneumonia, why the hell would you discontinue albuterol nebulizer? Why would you discontinue that? Why would you that don't even make sense. Because you know the man is still going to have shortness of breath. Why would you discontinue that order? That makes absolutely no sense. This is what I'm saying. Like, when people be like, all LPNs do is pass pills, bro. No, that is not all we do. LPNs be on the phone with people, be trying to fix everybody's mistakes, all that kind of stuff. It's just more than passing pills, bro. Because I'm going behind 3 different people. I'm trying to figure out what the respiratory therapist done said. I'm trying to figure out what the last nurse done did. I'm trying to figure out what the nurse before that done did. And why this man is sounding like a Honda Civic trying to start when he breathed. So anyway, I said, so clearly this note is bull crap. Clearly it's bull crap, right? So I called a doctor, and that's the thing. Once you get the history, you write it down. If you see any medications that kind of add up or line up with his diagnosis, you make sure you write that down. So you got your vitals, you got your history. And now usually when they have a lung issue or whatever, and see, another thing doctors like that I noticed, doctors like when you make suggestions. You know what I'm saying? At least from what I've experienced. But don't tell them. You know what I'm saying? It's like it's a way you have to word it. Not saying that I think you should do this because they the doctor. But if you suggest it, like for example, I'm gonna tell you how I did it. Hey, Dr. Such and Such, my name is CJ. I'm calling from such and such. I have a patient here. He has a history of COPD. He's statin at 80. And they like to see that you've taken initiative to do something. You dig what I'm saying? So he's statin at 80. Upon assessment, has wheezing sounds. I put 2 liters of O2 via nasal cannula. Got his stats back up to 90. But patient has a history of COPD, congestive heart failure. Would you like it if I put in an order for an X-ray and and is it okay if I reactivate the PRN orders that they had prior to yesterday? They'll be like, oh yeah, sure, go ahead and do that. Or if they don't like it, they'll be like, nah, I'd rather you do this instead. But doctors like it when you can take initiative and use common sense, you know what I'm saying, within your scope of practice. Not saying that you telling the doctor what to do, but if you say, hey, I was just wondering if I could do this, not saying, oh, well, you need to do this. You know what I'm saying? Because they the doctor. You got to respect it, right? Even though some doctors are nuts. But you still got to respect it. It's a way to do everything. But, hey, doc, patient, was statin in the 80s. Can I get it? Is it cool if I put in a order for a chest x-ray? And can I reactivate those PRN orders and everything? Blah, 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 blah. Usually they'll be like, yeah. And they'll be appreciative of you actually doing something, because people will see a patient that's going through some type of whatever they going through, and they'll be like, the doctor will be like, well, what did you do about it? Nothing. Just called you. And doctors hate that shit. They hate that shit. They hate that. Boy, that'll be. Now, I've never been cussed out by a doctor. Ain't no doctor going. No, I don't play that game. But I've always gone into it with respect, and I've always used my common sense. You know what I'm saying? Before I call a doctor, though, I've make sure I've exhausted every resource that I can use within my facility, within my scope, before I call a doctor. Because some of y'all will call a doctor for nausea and vomiting when the patient has an order for Zofran right in the mark. You just didn't look it up. You dig what I'm saying? Like, it be little stuff like that be irritating the hell out of doctors. So, and I get it to a certain degree, because I'm like, I will be like, why are you calling me for this? You know what I'm saying? Like, why are you calling me for this? So it's just things like that. But again, that comes with experience, and that comes with somebody who's thorough. Fortunately, I've been blessed to have a lot of thorough preceptors in my day. You know what I'm saying? And I'm not perfect, but mistakes can still happen. But I'm pretty good at using common sense, and I feel like I got a good sense of using nursing judgment. So I think once you get that down pat, that's probably the best. That's probably one of the most important things you can learn as an LPN. And that's why I like skilled nursing versus assisted living, because I'm not gonna lie, like in assisted living will make you lazy. And listen, assisted living was easy money. It was easy money, but I felt like I was too restricted as a nurse, because with it, at least how it was over here. Because in assisted living, you got to go through everything. Like, you have to put in an order for every little thing, at least here. I don't know how it is in other states, but in assisted living, you have to put an order. You have to call literally and get an order from a doctor for even Tylenol for a person with no allergic reaction to it. That's crazy, and it's a waste of time. That's a waste of time. If a person haven't had a bowel movement in 3 days, you gotta call. You literally gotta call and get an order for milk of magnesia, 30 cc's of milk of magnesia, when that's usually standard BM protocols. That's crazy. Who got time to do that? When all these patients, well, not all of them, well, a lot of these patients ain't moving much. A lot of them stay in the bed, and a lot of them be constipated. A lot of them on pain pills. So you know that's gonna come with constipation. I seen a lady, she was taking Norco 4 times a day. She wasn't on no stool softener, no Miralax, no nothing, bro. And always complained of constipation. And I'm like, see, I'm used to having thorough doctors. So I'm like, why is this person, she not allergic? Why is this person not on no kind of stool softener or no kind of some sort of laxative or whatever the case may be? Because you already know, once you start popping them Norcos like that, you already know what's finna come with it. Constipation, that's what it do. So it's just a lot of things. Like, when you a LPN, it's like you the middleman. Not only are you the middleman, though, you the middleman, you the therapist, you the healer, you a talker person, you the negotiator, you talk them off a ledge, you the lost and found, you all that stuff. So that's what I be trying to tell people. Like, do you know how easy my life would be if it was just passing pills? Like, if for real, if being an LPN was literally just passing pills, bruh, my life would be 100 times easier. What? It's not that, bro. It's not that. But when y'all deal with these doctors, you just gotta know what the hell you talking about, bro. Like, if you got a patient that had a fall, you know what I'm saying? You get the vitals. You start off with the vitals. You examine the patient. You start off with the vitals. Make sure their vitals are stable. You want to do your neuro checks. Knock out the neuro checks. And you want to do your head to toe assessment. Then you call the doctor. You let them know. Did the patient hit their head? Is the patient on Eliquis or blood thinners or whatever? You know what I'm saying? Like, all that stuff matters when you calling the doctor and reporting to a doctor. You Dig what I'm saying? Like y'all gotta, I just don't want y'all to get cussed out, because I know when a doctor be cussing some of y'all out, I'll be crying and all that kind of stuff, and then you be ready to quit, all that good stuff. So I'm just trying to give you the game on what doctors like to see, at least from a long-term care perspective. Doctors like to see you take initiative. Doctors like to see you have a sense of knowing what you're talking about or whatever. You said, have I ever thought about teaching? No, not really. Not really. I'm saying literally everything textbook, but that just come with experience, though. You know what I'm saying? Like, that just come with experience, and that's why knowing the basic things are very important. Knowing the basic things, and like I said, usually basic protocol, you get labs, x-rays, you know what I'm saying, blood work, all that kind of stuff, so you can get an idea and a range of what's going on with the doctor, with the patient. And you know, 9 times out of 10, they usually gonna ask you to get labs, CBC, CMP, BMP, you know what I'm saying, depending on what the symptoms are. But 9 times out of 10, like if you got a patient that's throwing up excessively and all that kind of stuff and lethargic, 9 times out of 10 they're gonna ask you to get labs, get a set of labs, get a set of labs, get a set of labs. But it really just depends, though. If you got a patient that's having some airway issues, you usually gonna get a chest x-ray. Or if you got a patient that's having some edema or whatever the case may be, you want to make sure a patient don't have fluid overload or whatever. You know what I'm saying? It's a number of things, but it's only so many things that the body can do, if that makes sense. So once you just get the hang of that, then you pretty much good. And that's kind of like why I do enjoy being a skilled nurse, even though some days it get irritating, but I do enjoy being a skilled nurse because it keep you sharp. You dig what I'm saying? It keep you sharp. Like, I'm at the point to where, like, I can look at a patient and I can know something is off. Like, you could just look within like 2 seconds and know something is off, because especially if you had the same patient over and over again, because that's just how the scenario is. But like I said, I like working rehab because it's fast paced. Long-term care is just too slow for me. You know what I'm saying? Long-term care is usually like when the patients be there, they residents there, and they just there. Long-term care, rehab is usually like when the patient's there for a couple weeks, they done had a surgery, or you know what I'm saying, they just came back from the hospital and they just recovering. It's fast paced, and I like that because, like, one, you're not bored, and 2, it just keep you sharp because you never know what's gonna happen. You never know what's gonna happen when you rocking like that. So I'm trying to think of any other tips that I can give y'all when handling or dealing with a doctor. I know sometimes some LPNs, like when I was working in assisted living, we would do rounds with the doctor. So how the doctor that I was working with did rounds, we would go over, like if he had a patient, like if he had any patients with some issues that we would write down in the book, or that another nurse has written in the book, they would go around and look at them. We would get vitals. See, it's always good to know, like, and that's why it's pretty decent to know to have a decent rapport with your doctor too, because when you know them, y'all develop a good relationship. Your doctor start to trust you. You dig what I'm saying? Like, when you start to develop a good relationship with your doctor, and you show him or her that you're not an idiot, they'll start to trust you, and your life will become a little easier. Because sometimes you and the doctor can become so tight, and you can know what he's gonna do. It just depends on your relationship. You can anticipate what he's gonna say, or he or she gonna say, and you could just throw it in. But that depends on the doctor, though. That's not every doctor, but you could just be like me and Dr. R, we was real cool. So I already knew with certain things, I already knew what he was gonna say. You know what I'm saying? I already knew what he was gonna do. Like, hey, Dr. R, this is CJ. I'm calling. I got a patient that's got these kind of symptoms, but I already put it in the lab, CMP, BMP. I got a chest x-ray. coming out, all that kind of stuff. He'll be like, all right, cool, thank you, I appreciate it. You know what I'm saying? Thank you. Because it just make their life a little bit easier. You know what I'm saying? And it make your life a little bit easier because you already can anticipate what they're going to say. And then some doctors, you'll get so cool with them, they'll be like, certain things you ain't even got to call me on. You know what I'm saying? Just do it. Because you got to understand, too, if you got a good doctor, they dealing with 80 other patients. You know what I'm saying? So it's just little things like that that'll get you over good with the doctor. You know what I'm saying? So you don't have to be worried about making a phone call. And then, you know, being a night nurse, sometimes you're gonna have situations where you call, you gotta wake their ass up. But you can't be like, I know I've seen nurses be afraid to call a doctor at 4 a.m. because they scared to wake them up. That's their job. That's their job. That's what they signed up for. They know they on call. Or you have a nurse practitioner, or they have, like, if it's the weekends, a lot of the times they'll have that nurse practitioner, you know, answer or take over for them. Or they'll have a physician assistant take over for them, whatever. But that's their job. You can't be scared to do that. What they gonna do? Beat you up? Wake their ass up. That's what they get paid for. Hey, listen, sorry, this be, you know, professional. Hey, Dr. Such and Such, I'm sorry to wake you at this time of morning, but this is why, and again, this is why it's important to exhaust all your resources out before you even call. Because yes, even though they on call, you don't just want to call them for some silly shit. You know what I'm saying? Make sure you take your vitals. Make sure you look up their history. Make sure you look up the protocols, what the standing orders are. Make sure you monitor. It's just a lot of things you do before you give them a call. You know what I'm saying? Now, if you got a patient that done fail and crack their damn skull, you really gotta call. You call the doctor once you send them out, and you let them know you sent them out. You know what I'm saying? So it's just a lot of that stuff is common sense. But yeah, that's how you really deal with doctors, from as far as I know. Now, I've never worked in a hospital, so I can't tell you how to deal with them in a hospital. I'm sure it's a totally different ball game in a hospital, so I cannot tell you how they work. But in this long-term care world, that's how they work for the most part. Even with the bad ones, because even with the bad doctors, if you hit them up like you got some sense and you're not afraid, because see, doctors can smell they can smell it when you intimidate them, and they don't like that. They hi doctor such and such, I'm sorry to call, and all that kind of, you know, you can't, they can sense that, and that irritates them too. They be like, bro, get to the point, what's going on? So, you know what I'm saying? Like, you just, once you build a rapport, and, you know, thorough, you know what the hell you're talking about, only thing they can do is either put in a new order or not, or discontinue an order, and that's pretty much that. I mean, it's really not that difficult. And make sure you document that you spoke to the doctor, and the doctor put in an order for this, you know what I'm saying? And shout out to Toya. But yeah, and Toya, I think I was supposed to. Did you ever send me an email, Toya? Because I was trying to reach out to you about the school, about some school stuff. But yeah, but that's how you do it, man. Like, doctors ain't really that complicated to deal with from a nursing home perspective. They're really not. You just gotta fill out the kind of doctor that you have. Ask around. Okay, can you send me another one? I'm gonna try to find it. But just ask around. You know, talk to your other nurses. Like, hey, you know, doctor such and such. How is this person? You know what I'm saying? What they like. So you can kind of get an idea of what they like, and you know, that is what it is. Like, it's not that difficult. It's not that hard. It's not that difficult. It is not that hard. Trust me, it's not. It's They people too. You just can't be scared though. You can't be scared like a lot of cats be on that timid stuff. They hate that shit because what you gonna do when some real stuff pop off? You know what I'm saying? Like what you gonna do when it really get real out there in the field and you have a cold blue and somebody not breathing and all that kind of stuff? Like nursing is quick. Like you can have nights where 30 days don't nothing pop off, but then it be that one night where everything go wrong. You can have two colds in one night. Then you gotta go and pump on somebody's chest. You gotta think quick on your feet, or you got a patient that failed and now they unresponsive and all that kind of stuff. So you gotta be quick, and that's why I like skilled, because in assisted living it ain't like that, bruh. It's just not like that, you know what I'm saying? And then like you end up losing some of that instinct, you know what I'm saying? Because you get an instinct when you in skill and you really thorough. You develop an instinct, that nurse instinct, that this ain't right. So I know like that must be tenfold for like an ER nurse or ICU nurse up in the hospital, because I know that instinct just multiply times 100. Because if you a thorough ICU nurse, you gotta learn how to take care of the sickest patient. You know what I'm saying? And that would be my, like, if I was gonna be a travel ICU nurse, I wouldn't even consider traveling until I could take care of the very sickest patient on my unit. And I knew how to do that. You know what I'm saying? Like, I wouldn't even feel comfortable with being a travel ICU nurse until then. And that's why a lot of these nurses be going on these travel assignments, not getting no real money, because a lot of them just med-surg nurses. And then like a lot of these travel companies like you, and I do understand that a lot of specialty nurses do be ending up working med-surg, but you do be having a lot of openings for specialty nurses because they need specialty nurses. That's why I said, like, even though like this ain't my, like, nursing is not my number one passion, I understand that I'm good at what I do right now. And I really believe I will be a great ICU nurse. You know what I'm saying? And it's all about developing a skill. It's not about what you love when you're trying to hustle and get something. You got to sacrifice now and get to the greater good level later to get to the next level that you want to get to. You dig what I'm saying? So you just gotta be thorough with it. Let me see. I'm in my first semester. Bria, how your first, is it Bria? Bria, am I saying it right? How's your first semester going? Let me see. It's sad how some people look down on LPNs to say that they're not nurses compared to RNs. That's not true. Hey, absolutely. Absolutely. For real. And listen, too, when you become an LPN, don't think because you're not good at one thing, you a shitty nurse. That's not true. Listen, I am awful at inserting Foley's on a female. I'm terrible at it. If I can find another nurse to do it, like, I will, because I'm awful at it, and it's difficult to do. For me, I know some nurses that kill it on the first try. They ain't even gotta look. They just get it and understand it. But I'm terrible at inserting female Foley's. Oh, and I got some nurse game for the fellas. But I'm gonna say it now, but I'm gonna have to drop it in another video just separately, because they shouldn't have, I don't want them to wait an hour, have to go through the hour line to get that game. But fellas, let me tell you something. If you have a female patient and you have to do any procedure like inserting a Foley, or you have to do a procedure where you have to insert a certain medication through her vaginal area, always, especially if you're in long-term care, have a female, preferably a nurse, but have a female with you. Do you hear me? You always have a female with you. It just saves you a lot of trouble. It saves you a lot of trouble just to have another female with you. I'm telling you what God loves. You always have another female with you when you are doing a procedure like that. And if If you cool, I would even add, because there are certain medications where you have to insert through the vaginal area. I would just ask the female nurse to do it for me. You dig what I'm saying? And if you cool, I've never had a nurse say no, I'm not doing that. Never. So usually they will do it. But if she don't want to do it, just make sure you have a woman with you, a woman healthcare personnel in the room with you as your alibi, so you can document it and make sure when you have to do a medication or you have to do a procedure like that, make sure that you document that you had a witness with you. You dig what I'm saying? So you just want to cover yourself, because things do happen. You have patients that have sundowners. You have patients that have Alzheimer's. You may remind them of somebody who may have done trauma to them from their past. You dig what I'm saying? So you always, especially if you got a patient who has Alzheimer's, you just always, when you doing like a procedure like that, you always have another woman with you. That is going to save you a lot of trouble. I'm telling you. I'm telling you what God loves. Let me see. Working in a group home, we had to call the doctors a lot. You must be ready to make that call. It's going. I'm coming in with no healthcare experience, and it can be intimidating at times, but I love hands-on learning and skills lab. Today is my first day at clinical. I'm super nervous. Don't be nervous. Just listen. Listen, write down the important stuff, pay attention. It become repetition. Would that be the same for female LPN with a male patient to have male personnel with them? Yeah, I mean, yes. Technically, yes. But, yeah, I mean, y'all know how that is. You know what I'm saying? Like, y'all know how that is. Because, yeah. But I wouldn't even say, I mean, yeah, you should. But even if it's another woman for a male patient, like, I mean, because y'all know. Like, y'all know. Yeah. And then, because 9 times out of 10, it usually be the male that's be trying to, the male patient trying to grope on the women and all that kind of stuff. So, I would say, yeah, but I wouldn't say it's more important than, because I'm telling you, it's just not cool being accused. Like, I've seen people get not arrested, but the police come and they got to investigate. It's just, I've seen males get accused of doing things, and like, we know he didn't do it, and we know, like, even when there'll be a female witness in the room, but that person will remind the person. Like, it was a patient one time that accused this guy of rape, but the person that she accused had Alzheimer's, and she looked, and I guess to her, he looked like the person that raped her from her past, and her daughter even saw the nurse that was taking care of her, and she said that she understands why her mom said what she said, because he does look really close. So that's why it's just good to have a witness with you. You know what I'm saying? It's just good because, and even not, it's a slippery slope with Alzheimer patients and memory care patients, because, like, this one girl, she got accused of, where I was working at, this one girl got accused of beating a patient in the face, because the roommate had another roommate who had Alzheimer's, and memory was crazy, and she had told one of the nurses, no, she told the DON that one of the nurses was beating her in the face, but she had no visible marks or anything like that. But they still, if the patient said, they still have to do an investigation and all that kind of stuff. And then when they asked the patient about it again, she said, I never said that. So, like, that's why it's like a slippery slope, but you always want to be thorough. You know what I'm saying? But it just look bad though, like, with when you doing like sensitive procedures that have to do with, like, the female genitalia. as a male nurse, you just always want to have a woman with you, man. Like, it's gonna save you a headache. It's gonna save you a headache. Let me see. A like B, like as an MA, yes, you learn your doctors. Yep, yep, you sure do. But yep, so I'm pretty much home now, y'all. I'm home now. Any other questions y'all want to ask me real quick before I get up off this thing? Did y'all see? I'm gonna get off topic a little bit real quick. Did y'all see? Old girl tried to play Michael B. Jordan. Did y'all see that? She tried to play Michael B. Jordan. He used to make fun of him. See what happened when you glow up? You know what I'm saying? People was talking stuff about you. That reminded me a lot of the nurses out there. They was broke before. You know, they might have been on food stamps, EBT. But as soon as you graduate, you start making that good money. You start flexing a little bit, living nicely and everything like that. Oh, hey, big head. You dig? Hey, big head. Oh, girl, you a nurse? Oh, big money. Big money. Oh, no, bro. No, I said, I was broke, remember? I was a bum ass dude, remember? I was broke. It want nothing to do with me. Now you see it shining. And you want to holler. No, no, ma'am. No, ma'am. No, ma'am. Take you and your kids and get on somewhere. But yeah. But all right. It don't look like y'all have any more questions. I'm going to stay on to the 60-minute mark just in case it's somebody typing right now. Any more questions, I will answer them. Let me see if I missed anything. Let's see if I missed anything. I don't think I missed anything. Okay. But yep, I'm going to stay on to the 60-minute mark, y'all. Y'all just get them last questions in. If y'all have any, I know it's still early. A lot of y'all probably still asleep. I'm about to be asleep right along with y'all in a minute. Yep. So, yeah, y'all hit that like button for a player on your way in and on your way out. But this was a good talk, y'all. I think we had fun today, this morning. We had fun this morning. Okay, Queen Butterfly said, how to deal with mean, rude residents threatening to report you to the state. Make sure you chart everything and ask if you can switch patients. That's really that simple. You let your supervisor know you don't feel comfortable dealing with the patient. You chart everything, and that's it. You literally chart everything the patient said verbatim. Put it in quotations. And you chart it verbatim, and then you ask your supervisor, I don't feel comfortable handling this patient, taking on this patient. This patient has threatened me. Then, if they're a decent supervisor, they'll let another nurse take the patient on. But you deal with it by charting and not dealing with it. You know what I'm saying? So, and that's, man, like I knew somebody, she refused her insulin when her sugar was 450. She got pissed. Oh, well, what can you do? She got the right to refuse. They have the right to refuse. Just like they have the right to fall. You cannot put patients in restraints. Just like you can't make them take medicine. They have the right to refuse. They are well aware. Only thing you can do is chart and document it. That's literally it. Let them know that you got 3 times, you attempted 3 times. You let them put it in a note that you explained the importance of the medication to the patient. Patient still is choosing not to take the medication. We'll continue to monitor health and safety. Doctor notified. Yeah, just don't return. Yes, I got switched, but then the supervisor gave me her name after I asked them not to. Oh, yeah, I wouldn't return. No, there's too many places I already get money to deal with that. It's too many places. You ain't got to deal with that if you don't want to. You do not got to deal with that. But all right, ladies and gentlemen, I think I am going to go ahead and hit the bed. So I'm gonna let y'all in a minute. I appreciate y'all rocking with me on this live. And I'll holler at y'all in a minute. Y'all go check out my other videos. And make sure y'all like the content, share the content with any other nursing students or whoever. And I'm gonna holler at y'all in a minute. Check one more time, see if there's another question. If it's not, I'm outie. Nope, no questions. All right, y'all. I love y'all. I'm gonna holler at y'all in a minute. Peace.